Good afternoon. That music, the jazz, always puts me in a good mood, no matter what I'm doing. I just have to listen to a few minutes of that. So thank you, Brian, as usual, for having that set up. Welcome to this week's edition of the New Hampshire COVID-19 Vaccine Alliance meeting. Again, for those who are new to this call, the mission that was developed in conjunction with the Division of Public Health Services is to convene stakeholders across Granite State to promote vaccine confidence, support accurate and consistent vaccine messaging, and foster coordination of the vaccines allocation. To do this, we promote public buy-in for the vaccines to increase immunization rates. And second, most importantly, act as a force multiplier to support both the COVID-19 vaccine communications and allocation plan for the state. Third, when necessary, counter misinformation on the vaccines, and fourth, to foster use of the New Hampshire's immunization information system. Our supporters, our sponsors of this, again, are Harvard Pilgrim, Anthem, Gary Medical Center, Convenient MD, WellSense Health Plans, and New Hampshire Healthy Families Health Plans. So some takeaways from this past week, as you probably heard about the governor's announcement last Thursday, beginning on Monday, April 19th, all out-of-state individuals, college students, people that have second homes, visit or just visiting the state, can get and register for the vaccines. And anyone who wants to schedule a vaccine, though, has to register through Vinnie. The email address is there. Also important part, that discussion, why that's happening, will probably play into our latter discussion with Dr. Jonathan Ballard. And second, if your practice or facility is interested in becoming a vaccine provider, has to download and complete and complete back and send back the provider agreement that is there. And we'll send these slides out to everyone. After this afternoon, will be on the Medical Society's website. So if you miss this information, we'll get it back out this afternoon and we'll let you know about it. Next slide, please. So just a recap on the New Hampshire Immunization Information System. It is scheduled to be reopened this Thursday, the 15th. And the information that you've seen previously is available at these websites. Next slide. And as we mentioned before, it was sunset on April 1st to essentially roll over to the new system away from the VaxNH old ordering system. And again, this Thursday, it'll be starting up in place. But most importantly with the system, next slide, please, is if you want to use the system and any of your sport want to use the system, they have to take the web-based training module. It's about a 30-minute module. They do have to pass the test. And you can go to the website there, https www.train.org/cdc-train. Sorry. And what we also discussed in preparing for some changes in the allocation process and transitioning. One, make sure that you and your staff are trained up on the New Hampshire IIS. Review the design workflows, have available vaccine FAQs and other information to distribute to patients. And there are some sites again here that we talked about that help with vaccine messaging and promotion. And here's a copy that we have and we've been distributing. This is a brandable set of FAQs. It is in MS Word, so you can take and develop them however you would like and use. If you want to make changes to those, that's fine. This is just a base document. If you want to put your logo on top of it, it was developed in conjunction with the New Hampshire School Nurses Association and the Hospital Association. Also, we wanted to bring to your attention these other Division of Public Health Services weekly information system. Most importantly, this issue that just was announced today, and about an hour ago, HAN COVID update number 4 40 talks about the pause in administration for the Johnson & Johnson Janssen COVID vaccine. And what we know from that is it involves 6 reported cases in the U.S. of cerebrovenous sinus thrombosis, or CVST. At this point, the administrations of those doses are being halted. I think Dr. Chan and Dr. Talbot are planning on Thursday to give you a more in-depth report. So recommendations at this time aren't available until the Advisory Committee on Immunization Practices convenes. I believe it's going to be tomorrow. They're working, the department is working with the vaccine administrators to partner to make sure that there's alternative supplies available of the mRNA vaccines to continue operations. And as I mentioned, please tune into the Thursday at noon session with Doctors Chan, Talbot, and Daly. They will go into more in-depth discussion on this. I don't think we're going to highlight too much. There's not that much available, except for from the press statements from the FDA and the CDC. It says, in this setting, administration of heparin may be dangerous and alternative treatments need to be given. So again, there's no clear guidance on therapeutic treatment for these events, but we anticipate in the next couple of days that that information will be coming forward, and please tune in Thursday at noon. Next slide, please. So, and one more click, maybe one more. We have as our guest today, Dr. Jonathan Ballard, who is the Chief Medical Officer for the New Hampshire Department of Health and Human Services, where he provides clinical oversight for the department's activities, including Medical Director for Medicaid and Public Health since 2018. And he's an associate professor at Dartmouth College. He previously was the state epidemiologist in Kentucky and ambulatory services medical director for the University of Kentucky Department of Family and Communication Services. He received his medical degree from the University of Louisville, a master in philosophy in epidemiology from the University of Cambridge, England, and a master in public health from Dartmouth College. He also holds academic appointments at Geisel Medical School and is a fellow of the American College of Preventive Medicine. Dr. Ballard, welcome today. Thank you for joining us. We were hoping you could give our audience today a little bit of an update of some of the about transitioning from the I guess what would be a state-run or state-dominated vaccine allocation process to more of a private one, as we see the numbers of those willing to have vaccines begin to trail off, what that might look like, what are some other things that are influencing some of those decisions, and what is maybe the general timeline that we might see some of these transitions begin to happen.
Thank you, Jim, and thank you to all persons that have joined this call today, and thank you for your work throughout the pandemic, and especially as we enter this new chapter of vaccine rollout in the state, and as Jim alluded to, potential transition, the expected transition from state-run sites and state fully administered vaccine program to getting it back in the traditional healthcare, how vaccines are typically administered. It's an exciting time right now. We believe we have about 60% of the state's population who either have had a COVID vaccine or fully immunized or have an appointment coming up in the near future. So that's exciting, but also enlightening that we have some challenges before us to reach some key populations, not only those that are vaccine hesitant, but more the population that's just vaccine ambivalent. Happy to take it, but not necessarily going to go schedule an appointment and go through a fixed site and take that proactive step, but would be willing to take that vaccine when they come into your provider offices, to urgent care centers or pharmacies, as this transition happens. There's a lot of moving parts, and we are working diligently to address many of the components to make that happen. We are still in the setting of demand exceeding supply. That was true before today's excitement with the pause of the Johnson & Johnson Janssen vaccine, as well. So we're still receiving allocations. They have been going up, but not skyrocketing up in our allocations to New Hampshire of the Moderna and the Pfizer vaccines. Although we have seen increases in those two. It was reported nationally even before today's pause for the Johnson & Johnson vaccine that we should expect over the next 3 to 4 weeks much lower numbers of that presentation coming into the state. So today's news doesn't really affect the logistics a whole lot, other than the information that went out to you today in the Health Alert Network message about be on the lookout, continued surveillance for anyone who presents with symptoms of a thrombosis, and the news of don't use the heparin family of products for anticoagulation from a clinical standpoint. Use the other types of anticoagulation that's present if you were to come across that. On that front, just to address it very briefly, 6 cases out of nearly 7 million doses of the Johnson & Johnson vaccine administered in this country had this, extremely rare but very serious complication. We have not seen this complication in New Hampshire, and we've delivered about 37,000 doses of the J&J vaccine here. So statistically seeing, we are very unlikely to see a case if that probability holds up, if we don't have more cases that are determined through increased surveillance. We have, just as well for messaging, if your patients or those that you're wanting to receive information, there is the Health Alert Network message that's been pushed out to healthcare providers to help them with the understanding of the scenario, but as well, we have provided good, solid talking points to our 211 call center, and they are available to receive calls and address any patients' concerns who may have received the Johnson & Johnson vaccine already. So with that, we're moving in this transition period. So right now, vaccine is administered at the state fixed sites operated by the National Guard, as well as many hospital partners throughout the state, particularly in the northern part of the state and some of the southern parts of the state, as well as those vaccines that are being administered through the National Pharmacy Partners Program. Likely pretty much in the next week or so, all pharmacies, all chain pharmacies, and even some of those that I thought were independent pharmacies that are connected with a network of independent pharmacies will be receiving vaccine and standing up, as well as the onboarding of some urgent care centers and other types of scenarios. But those are all primarily done through open points of distribution or open pods. I'll pause if I'm seeing some stuff in the chat. If anyone has questions throughout, I'm happy if you would like to just put those in the chat, and I'll be ending soon, just that way we can address whatever questions that you have of the day. But the question is how do we transition from these open pods where everybody can schedule into it by the one centralized system that's on the vaccines with an s.nh.gov or calling 211 to the traditional healthcare setting, and when is the right timing for that? As of right now, we've opened it up already to any Granite Stater who wants a vaccine that's eligible for the vaccines, ages 16 and up. And we have appointments scheduled now through Memorial Day. And we're starting to see some declines in the requests for these mass vaccine clinic types of appointments. So with that, it makes sense that we will be seeing less demand and continued steady supply, hopefully, and that transition would happen over that time period. there's several steps that we're having to do. There are still issues with the challenges that we have to address with the way we receive vaccines from the federal government, meaning that there are minimum orders that the CDC requires of any practice to have to order. I think it's for Pfizer, it's still like over 1,000 doses you have to order at one time. And there's certain very specific safe storage and handling requirements, as well as it is both the state law and nationally required for us to report back all those dosage administration information through either the state immunization information system, known as the IIS, or through the documentation half of the VINI or VAM systems. If the appointments are now scheduled currently in the VINI or VAMS system, that data gets automatically reported back. But as we would transition and you would use your own electronic medical system or whatever scheduling software you would have, it's still required that dosage information gets reported back through us and eventually that information making it back to national numbers and to the national count and making sure that every single dose is accounted for. And that's in addition to the ordering functionality of the IIS, the transition there as well for placing orders. So there's several key steps that the state's working with different partners to set up. That includes onboarding partners and teaching them, as Jim alluded to, about how this IIS, the Immunization Information System module, works, the fairly straightforward training programs, and such. I think we're very fortunate. We have a very good product for an IIS. I actually used this product when I was a state epidemiologist in Kentucky in onboarding practices. Providers there, as they got onboarded, had a lot of great feedback. It has a lot of functionality. It's a one-stop. And as we transition into that over time, I believe any growing pains or experiences we will have will improve over time as we make this transition, as well as allowing us to transition how we deliver vaccines. Right now there's this need for mass clinics, and it will slowly go away. You may have some smaller clinics, 50, 100 persons as we get into the summer, but we're going to be identifying less persons that would need a large vaccine clinic per se. But we will have increased need for doing that vaccine outreach and increased need for vaccine equity outreach as well. So, then we will need to think about how do we make it easy? How do we make it easy for persons to get a vaccine? That's for that, the opportunistic opportunity for the vaccine ambivalent, whether that's protocols in the office of when you just see patients, so here's your COVID vaccine as well, normalizing it, addressing the questions, using those FAQs you have, to doing other things like protocols, standard processes like we've done with the flu vaccine and emergency room protocols, or non-traditional office protocols where here's your vaccine as well, to make it easy for people who may be coming into contact with the healthcare system, whether it's a pharmacy or an urgent care, any type of a provider office or a hospital setting. That's going to require then some logistic challenges that I would encourage you to start thinking through now if you have not done so. Thinking through proper vaccine safety and handling. What do you need as far as equipment to do so in smaller numbers, dispersed more throughout the hospital system rather than a central large clinic. Also think about standardized protocols, how to make it easy. You can look back to your flu protocols. Also think about the documentation. This is where it may be some challenging because it is still a requirement that we report back any the dosage information. So, you could still use the VINI or VAM system for scheduling if you want, but that's not designed for, appointment here and there. But it does have modules for reporting the data back, as well as the IIS system has a module in it for single vaccine manual order entry. So if you were to document it in your health record system, you would have to document it as well in the IIS. So thinking about the staffing on that and what your needs may be to have the, essentially double documentation. The other component that this department is certainly working with, and I've went through this in other states, is the onboarding of large practices, hospitals, through the automatic data reporting from these sophisticated EMRs to the state's IIS through what's called HL7 messaging, packets of information that would essentially come straight from your EMR, so there would be no need for double documenting. But that's not the norm anywhere in the entire country. Most small practices have, double documentation where you would enter it into your EMR and then also enter it into the IIS. And that's a standard practice across the country that we haven't had to experience yet in New Hampshire, since we've primarily done a state-delivered vaccine program, as opposed to many of the other states who have kind of done it haphazard and all over the place. And I think we've done it, at least for this initial rollout, where we've had extreme demand that could not meet the supply, to do it in a very organized way, one website, one call number, but also maintaining that need to work on equity and outreach teams, working with the public health networks and mobile teams. So my ask for you, and this is something the department's going to be doing over the next coming weeks, is to meet with stakeholders, including Jim and the medical society, as well as all the hospitals and then the federally qualified health centers and their association, to see what are the needs, what are the challenges, what can we help you work through, are there financial needs, what is the issues that will help us make this transition easier for you, for the system, and for the patients, so we can bump up that percentage of persons to be immunized. If we're at that 60% vaccinated, there's some probably additional persons who have some level of natural immunity through contracting COVID-19, expected to wane off over time, that immunity. But we need to increase it. The other factor we need to start thinking about now, too, is the pediatric population. I think we're seeing reports that the Pfizer vaccine will likely have a increased population it can go to for those 12 to 15-year-olds probably first. What does that mean for you? What does that mean for consents? What does that mean for legally? Are you going to want a parent to be present in the office and the location when they get vaccinated, or are there other types of consents that you would want to work through? So those are some things to consider. So if we're looking at transition time period, the governor, different ones have said that we're looking at Memorial Day as a shoot date for making sure that we really work hard, push our efforts in the state fixed sites to get as many people that first dose and transition over time, with making sure we do our second dose as well. But transitioning into the traditional healthcare setting is the expectation, as we have no further need for these large mass clinics. But we enter into a new phase, a lot of hard work. There was a study from the de Beaumont Foundation that said that one of the most important factor for the vaccine hesitant person to receive a vaccine is a conversation with a trusted healthcare provider. So that is important information. I understand there's going to be some Project Echoes going on, as well as the outreach work with the medical society, and that you've seen in a lot of the FAQs and talking points of how to discuss with patients in the most productive way. I know Dr. Elizabeth Talbot has been a leader in this, and she has some excellent presentations. If there are some larger groups that would like to receive that information, she has offered to meet with different groups and to share her presentation as well. Again, I want to plug on for Thursday's Healthcare Partners Talk from 12 to 1. Jim had the link to that call as well. I think Dr. Chan's still on vacation, unless you've heard Jim, he's going to come back for that talk, but Dr. Chan's on vacation this week, but Dr. Talbot will be available, Dr. Daly. And we hope to learn more from tomorrow's advisory committee on immunization practices meeting about the Janssen vaccine issue. What this pause means, if it's going to be something similar to happen with recommendations of the AstraZeneca vaccine in Europe and Canada, or what the recommendations will be. We hope to have some more information for you on Thursday. We did scramble this morning and checked with all of our partners who had received some doses that were remaining of the Janssen vaccine and have offered and been able to get some Moderna and Pfizer vaccine out to them to try to ensure that all those persons with scheduled appointments are able to keep those appointments if they're willing to accept that different presentation. So I think with that, I'm just going to be open for questions and see where we go, Jim, if there's anything else you want to address.
Yeah, so just to take a quick step back, I think it was about 2 weeks ago or about a week and a half that the department surveyed, the division surveyed all those who had provider agreements already or in other interested parties to see specifically what their interest in was, potential ability to distribute vaccine. So that started this, and as you mentioned, starting this week, all pharmacies who have an agreement through the expanded federal program are now receiving vaccine. But that's separate, as I understand, from the state's allocation process. Is that correct?
That is true. This was actually one of the curveballs I think we've seen from the CDC over the last couple of weeks. We saw the news that the production was increasing at the Moderna and Pfizer facilities, and that the national, level of vaccines would be increasing. And so we anticipated more coming into the state, but where we really saw a lot of those doses go was direct allocation from the federal government to their partners. So there are I believe, 3 or 4 now direct distribution programs that the federal government does. Fortunately, all those partners still work very closely with us at the state. So there's the Federal Pharmacy Partners Program, where pharmacies are directly getting it from the CDC, as well as there is the Long-Term Care Partners Program, which had its big doses come in December, January, and February, but they're still receiving doses now for their continued locations. I believe it's winding down. But then we also have the dialysis partner program, which is the allocations that can go out to kidney dialysis centers, particularly vulnerable population for severe outcomes. I think we actually vaccinated the majority of those persons already in New Hampshire, so I'm not sure how live that is for New Hampshire, but across the country, especially in the southern parts of the country where we have very high rates of chronic kidney disease, and that's apparently been a very important program to address health equity as well. So those are some of the federal programs.
Yeah.
And
so
we have the state.
Talk to me a little bit. What was the response during phase 3? Was it about what the state anticipated getting in, or is it more or less?
You say phase 3?
Phase 3 for phase 3 of the allocation process. So essentially, everyone 30 to 16. Was that about what you expected, or was it less?
We continue. We go from week to week essentially with what we're hearing from the federal government. As far, they're supposed to give us 1 to 2 week projections, and so we monitor that. And we monitor the demand for vaccine. And that's allowed us to actually speed up the phases much quicker in our time frame than we thought we could do them. So we made our projections, 3 months ago, published our expected time frame. But each time as the doses keep coming to the state and we keep on getting the doses in arms, we were able to speed up where we're at in the phases. And unfortunately, we're able to make that I believe it was only New Hampshire and Utah as the only 2 states that are, as of next week, will be able to allow any person, not even just state residents, to receive a vaccine, just because we're at that point where we'll have the vaccine, we have the manpower, or the person power to put the vaccines in arms, and the doses here. So the expectation.
Yeah, so it's, as I was just reading a report, I think New Hampshire is leading the nation right now in the amount of vaccine that it's used. It's like 95%. And so doing really well, probably
Yeah,
both.
so 90% of the doses that were allocated to New Hampshire have been administered. That leads, it's the highest percentage of any state in the country. We have one overseas U.S. territory, Palau, that surpasses us as far as actual per capita persons who are vaccinated. That we also lead, we're also leading in per capita vaccination with right around 50% of our population getting a dose. So at least getting started on their series or completing if they have the Johnson and Johnson. I think Palau is where they had Survivor at. So you ever seen that show? I never heard of it until Survivor.
Let's dive into some of these questions, Dr. Ballard. So let's talk about the next potential phases here. And the question is, will vaccine be equitably distributed between open and closed pods? Or will open pods receive preferential or more distribution? How do you anticipate that occurring?
Right, so you're really talking about the transition. So right now, it's primarily open pods, meaning that we don't have enough vaccine to give to any one particular healthcare provider over another, and then that vaccine being, exclusive to only their patients, and then not available to say another provider who doesn't get the vaccine, because we don't have enough vaccine yet at this moment to do, all the providers. And that would cause more inequities if we just were to go to closed pods immediately. It wouldn't, then you would have issues with access for these persons who the category in the category 3 persons to sign into. We do closed pods specifically through the regional public health networks and the two full-fledged health departments in Manchester and Nashville to do equity allocation. That's our vaccines that we're trying to get to those populations who are at increased risk, for not only severe outcomes, but for persons who have been historically increased affected by the COVID-19 pandemic, disproportionately affected persons. And so those are closed pods where it is scheduled for only certain persons, not publicly advertised, not on the VAM system, not on the vaccines.nh.gov sign-up system. So then the transition then will be letting those appointments that are in the VAM system through our state fixed sites kind of work their way through the system. As we see the demand for those appointments decrease, we're going to be gauging our ability to start allocating out to the healthcare sector for closed pods. So you're going to kind of see the fixed sites appointments, just the demand essentially going down, even though we could do more, but you're going to see the demand go down. At the same time, we're going to be watching that and then seeing how we can increase our allocations. That's why I'm asking you now to make those preparations for what do you need, what are their barriers, what are your challenges, and let us work through the hospitals, the medical society, Bi-State Primary Care, and others to address those over the next few weeks before we say that transition is fully made. We're getting towards the middle of April, and if we say towards the end of May, Memorial Day, as that transition happens over the next 4 to 6 weeks, we want to make it easy and to make that work for you.
Right. Here's a more specific question about the vaccine. Do we anticipate that the vial size will get smaller or into single doses, or do you think it's going to be produced?
I don't see that. In fact, they're going the other way. We see, I think it was Moderna wants to package 15 doses in one vial now. So unfortunately, that's the real challenge, is that we're actually needing to go to smaller doses for outreach, equity, integrating it back into primary care or protocols. That's the challenge, is how do we do that? And we need to all think through that ourselves. Does it require more freezers? trying to figure out what your volume of unvaccinated persons who might accept 1 3.5 day clinic. Good news is there was some increase in the amount of hours that the vaccine can be both stored in a fridge or actually out of the fridge has increased. And that was actually very helpful to us this past weekend at the Speedway site, because we could draw up a whole day's vaccine early in the morning. Could draw up 6,000 vaccines that morning and put them in a fridge and then get them on out onto the floor of the vaccine site and not worry about the timing, because we knew we were way within the time frame. So there are some things that are helpful, but then the actual number of doses in a vial is not helpful.
Right. All right. A question about does the NHIIS require vaccine data entry for all vaccines or just state-provided vaccines?
So it's a list of reportable vaccine. Let's take that back. I'm going to have to defer that question to other partners. My understanding is that it is the law for the COVID vaccine. And then through the Vaccines for Children program, the state ordered vaccines, that is also a requirement. So if you're able to receive your vaccine separately from the state system, and it's a non-COVID vaccine, that may be a different setting. But if you're a partner in the Vaccine for Children program, you must report your vaccine information as well as all COVID vaccines.
Great. A vaccine question again about J&J. Although the state is planned for very little J&J over the next 3 weeks, is it part of the state's plan for future allocations?
Can you repeat that, Jim?
Sure. Although the Janssen J&J will be, there's very little supply anticipated over the next 3 weeks. Do you anticipate that J&J, the Janssen vaccine, being part of future allocations for the state?
Yeah, I anticipate that the advisory committee on immunization practices are going to make some determination tomorrow about its use. I mean, I'm not certain what they're seeing, the data they're seeing, whether they will, want to restrict it to certain populations or not, or whether that's such a rare event, 6 persons out of 7 million, that they'll say the benefit overwhelmingly is good, because the number of lives it is saving every day through its administration, lives that would be lost to COVID otherwise. So it'll definitely be, part of the mix. When we get far down the road, and we're all ordering through the IIS and managing the vaccines, and we get to this vision of automatic reporting through the HL7 messages through most of the hospital system practices, it's extremely easy to use of a system where you actually just pick which doses you want, and they are directly shipped from the distributors to you, just like all the different types of vaccine choices that you would get, if you're for all the other childhood types of vaccines and the other adult series.
Great. Okay, just on the communications front, if a practice submitted a provider agreement already, should they be received a confirmation of its receipt from the department, or how can they confirm that that agreement has been received, and what do you think will be the communications in the next few weeks between the department and those who have signed a provider agreement?
Okay, so first of all, if you're concerned where your individual setting is, you need to email us. Jim, if you can, I'm looking for the email address for those questions, but I know Jim shared it earlier and has been sharing it through the weekly Medical Society newsletter as well. It's shared in that. So go find that email address and make sure you reach out to it. We have a couple of different email addresses used for different purposes. If you have any question there it is, and C19 enrollment at dhhs.nh.gov. So that's the enrollment into the vaccine distribution. There's another separate email for questions about onboarding into the IIS. And I can pull that up real fast. Here it is. I'll put it into the chat box as well. This is nhiis.support.dhhs Doug. .gov. Put that in there too. So that's the question about the IT onboarding on the IIS, and then we have the enrollment email as well about your individual setting.
The other question here related to that is, should practices anticipate vaccines to be available through the normal pharmacy supply chain channels going forward? And I don't know if this is
I don't see that soon. I see it still being ordered through a government system, through federal government, through coordinated by the states, through a state platform such as our IIS.
Great. Looking forward, what do you think about the distribution of vaccine to children and adolescents? You mentioned earlier information about Pfizer to the 12 to 15 age group. Do you anticipate that that cohort will be given vaccine before the beginning of school next fall?
Well, I think so. I think that we're looking at summer for that, is what we're hearing. Likely would happen after we start making this transition. I mean, as our appointments go down and we no longer really need the fixed sites, and you're really doing the hard work of one-on-one conversations with your patients, I think that's when we'll be transitioned to the healthcare setting for vaccines, and that likely will be when some announcements come out from Pfizer, and then I know there are studies going on now as well for Moderna and the others. And so I don't know. I mean, it's obviously whenever they get the data back and they feel confident in it, and they apply for an emergency use authorization. When that timing happens, I mean, sometimes they drop that and we caught off guard.
Right. I think we addressed another question here about the vaccine size, and at this point, they're tending to move in larger dosages, not smaller doses. But as you mentioned, that's kind of the paradoxical situation we'll probably be in as we move over the summer here. A more specific question here is, with the National Guard changing from their site from South Nashville High School to the mall, are patient appointments and return appointments remaining?
I don't know.
So if I can reinterpret that question, I think it is I understood from the release that any current appointments to South Nashville High School were automatically transferred to just the site. So the timing, the appointments don't change, it's just the location. Those have all been moved over to the mall, is my understanding. Okay. There's a comment here. The double documentation requirement will be difficult for many of us. Could the state provide assistance to help with the cost of the extra administrative work?
I think this is something that would be helpful for us to hear from you. What are your challenging? I do want to note that if you're billing for vaccine through as this transition happens, you should take a look at the rates. The rates were dramatically increased last week at the federal level for the individual rate that you would be reimbursed at. That we haven't actually experienced this much in New Hampshire because we've been operating it from direct support program where we're directly billing, getting grants from the CDC and paying all of our fixed sites and all of the National Guard and operating costs, paying the hospitals that have been doing these big, large open pods and such. But much of the country is billing insurance, and the rates were significantly increased. I think to accommodate some of these issues, the increased costs that are associated with this that haven't been, appropriately paid for with regular vaccination or just to make this easier for facilities. But yes, we need to hear things like that. What does it actually take to document it once in your EMR and then document it in the IIS?
Great. Have you been hearing any information on potential booster doses?
I don't. That would be a good question for Dr. Talbot. She's been paying close attention to all of the science, and reading the primary literature, and then trying to discern what the proprietary information from the big drug manufacturers have been saying.
Right. So our last
so-
question that we have here, and please, if you'd like to submit any kind of last minute questions, please, here is kind of going back to where we started. What is the strategy to reach the vaccine ambivalent? And I think you mentioned in part it's any point of the healthcare system.
Yeah.
Essentially.
That's the strategy going forward. We look in reverse. We're just trying to make it as easy as possible for the vaccine ambivalent. And that's why I believe New Hampshire has the highest rate of any state in the country, is because we made it easy. We were the only state that had the one website, the one phone number, the state-run system like that. I mean, there's a few other states similar, but not as easy as New Hampshire. Most states did it like, look at our neighbors in Massachusetts, where they just said, call your provider, and your provider didn't have it, and you had to call 100 places, and this whole underground network of helpers help, the elderly and others to find a vaccine dose. Where we didn't experience that in New Hampshire. We from the forefront, we learned from our experiences with the H1N1 outbreak, and we said, well, we can do it slow through that system, or we can do it fast. And we can make it easy for the vaccine ambivalent to make it easy for everybody. And that was the way we chose purposefully from the start. So, but now we're kind of getting past the need for that. We're starting to see less people sign up. We will do some PSAs and try to, get it increased, and talk about how easy it is. But, the hard work is ahead of us. That's that one-on-one conversations, and also catching that opportunistic moment when that window is open, when you see patients in different healthcare settings where you can vaccinate. And that's where we really need your help. That is to think about those protocols, where you want to do it, the logistical challenges with the vaccine presentation, the doses, the safe handling, as well as the documentation.
Great. Well, Dr. Ballard, thank you very much for your time today. I think that's a great place to end. That is our big challenge I see as we go over the summer. It's how do we continue to make it easy to get doses out to those more hesitant populations? How do we address their questions? How do we, minimize their reluctance or ambivalence to moving forward? So that appears to be our challenge going over the summer, and it will fall more to, I would call the private administration of vaccines as we move through the summer. So I anticipate will probably be some opportunity to share information, some targeting of communities that appear not to be as responsive, but and possibly, as Dr. Ballard mentioned, that there will be resources available to help you kind of meet the challenges of doing this administration in closed and open pods as we kind of move forward over the summer to these more hesitant populations. So again, Dr. Ballard, thank you very much for your time, much appreciated. Folks, everything that you see in the chats, all the links and all that, plus a tape of this conversation and the slide decks will be available likely later today on our website. And if you come through the Zoom system, then we'll have captured your email and we'll get that information out to you when it's available, hopefully later today. So again, thank you for everyone for participating today, and we'll look forward to seeing you next Tuesday. Thanks again.
Thank you, everyone. Bye.